I'm aware we paid the Linda Mama claims early this year, and after we paid, we are still waiting for reimbursement to make the other payments. So kindly bear with us, and to promise you it will be paid. The national government has assured us that they will be sending reimbursements soon. I'll take you through the membership. As per the Kenya population, as per the Kenya National Bureau of Statistics, the Housing and Population Census that was done in 2019, Kenya has a population of 47.5 million members. Now, if you are to translate that into NHIF coverage, in our database we have 15.7 principal members. When you add the principal members and declared dependents, when I say declared dependents, the average size of a family in Kenya is approximately M+2. Then we have 35.9 million members that are covered. This translates to approximately that 75% of the registered members of of Kenya are covered by NHIF. But one thing I want you to note, it's not enough to be covered, because when we look at the database critically, the active members, and when I say active, I imply members of regular and good standing, who've contributed premiums up to date, then it is at 6.7 million from 15 million, or rather 43%. You can see the trend analysis of membership growth for the last 6 years. You may note from 2018, membership has been increasing up to the current membership, whereby we do have 15.6 million members that are captured in the database, including the 1 million indigent households that are sponsored by the national government. When we look at membership per sector, we have the formal sector, which has 4.8 million members. The informal sector, these are the self-employed members at 8.2, and finally sponsored program at 2 million. Allow me to mention something on the informal sector. You can see the numbers there are at 8.2. When we go to the active members, this self-employed, membership is at 1.1 million. What am I saying? Retention is at an all-time low at 14%. We are saying that for every 100 members who register for NHIF new members, at the close of the financial year, the members who still remain in the database, the loyal members, are 14. And when you do interrogate the database, you realize that these 14 are ailing from chronic ailments, subjecting NHIF to a condition that is known as in insurance as adverse selection, whereby we do have members who are sick who are joining the fund. Allow me to take you through the UHC scale-up, and in the first phase of the UHC scale-up, the government of Kenya was to sponsor 1 million indigent households, or 20% of the indigent households in this country. And we did receive data that was submitted through the counties that was of 1.5 million indigent households. We have so far registered in our database, after, of course, verification through the internal population registration services, or IPRS, we have registered 882,000 members, which translates to 88%. We have a balance of households not submitted of 120, and we've so far enrolled 382 biometrically. I'll mention something on this data. When we started, we had a number of challenges, because the data that you submitted through the counties and the State Department Social Protection was what we call unstructured data. Out of the 1 million households we received, 30% or 300,000 after verification were rejected by the system for the following reasons. One, they had what we call null values. An ID typically has 7 numbers. Some had 9, some had 5, and as such the system rejected. The other one, we had duplicate ID numbers. Some of your staff in the county copy-pasted, and they ended up creating duplicates in the data they submitted. Some other members, and it boils down to the people who did identification of indigents, both their relatives and friends who are in gainful employment. We had instances of some counties whereby we had members of the county administration onboarded as indigents and many others. Due to the constraint of time, I'll briefly mention the benefit package that the indigents are entitled to, and for that matter, we have 10 benefit packages, which includes the outpatient, inpatient, the highly patronized surgical benefit package, oncology including chemotherapy, radiotherapy, and the latest technology in town called brachytherapy, the maternity benefit package, renal dialysis, the diagnostic imaging or radiology. We have the new package in town that we just refreshed the other day, which is known as the mental and behavioral health benefit package. For our brother in Lamu, we've taken care of depression, schizophrenia, and considered it under the mental illness. We have the emergency road evacuation services. By a show of hands, how many know the emergency evacuation toll-free line? Wacha tuone people who know medical insurance. The deafening silence I'm hearing means that no one knows that NHIF has an emergency evacuation benefit package. This is the only time I'll allow you to remove your phone because you need to have this. This is your take home as you go back to your family. If they ask you what you learned in Pride-in, tell them that at least you saved the number for the emergency road evacuation services. It is 1199, that is a toll-free number. Or for Safaricom users, it is 0700 395 395. That number will take you to Red Cross. We have a program called E+, whereby once you call, you identify yourself by giving the ID number. The dispatcher will ask you the location of the road traffic accident, and they'll be able to dispatch an ambulance for purposes of administering first aid and the transportation to the nearest panel and contracted facility. We also have overseas treatment for ailments that cannot be treated locally. We do pay up to $500,000 shilling in India. I'll mention something briefly on contracted HCPs. We have 8,039 as per the latest data, and from the diagram you see 75% are government facilities. And when it comes to healthcare providers at NHIF, they are classified into two. We have the comprehensive contracts, whereby the whole bill is covered by NHIF. We have the non-comprehensive contracts, where NHIF covers a daily rebate, then the member co-pays the rest of the bill. We get questions that these high-end premium facilities, NHIF did not do what? Pay for me. Ililipa tu kitanda. Kweli? If you go to the high-end premium facilities, you know them, the big five. Nairobi, Mpisha, Aga Khan. Yeah, we will only pay the daily hospital rebate. Some of the costs per night go up to in excess of 300,000. So I'll jump the payout ratio, whereby you've been seeing that in the last few years, from 2018, the payout ratio has been on a steady increase to the extent that the claims experience is about to supersede the premiums paid. There was a question that was posed yesterday, pesa inaenda wapi? I want to confirm that the money goes towards payment of medical bills. I'll show you later as we move by. I'll go to now the UHC scheme, which touches directly on youth. That is the global picture I gave you. Now, I'll start with the outpatient benefit package. Now, we've done a utilization review for the period up to September, because this UHC contract, MOU, we received premiums on the 1st of January 2022 for 1 million indigents. That is, we got 6 billion. That was to take us up to 31st of December. For the 9 months under review, we have a total of 65,000 members who visited in excess of 1,200 outpatient care facilities. The analysis reveals that, one, the principal members are the ones who are accessing services. You can see them at 14,000, followed by dependents. And lastly, we have the spouses. Whenever we do this presentation, I do get worried because we might end up, missing the objective of UHC of leaving no one behind. My appeal to you this afternoon, as you go back to your respective counties, ensure that you touch base with the community health volunteers who identified these indigents, to remind them, because we did train them 3 months ago. We were in the counties for the old CCs, they'll bear testament. Nandi, did you see our team train CHVs in August this year? Among the things we trained them was NHIF processes, declaration of dependence. How do you declare your wife and children? For your wife, you need a copy of the marriage certificate. For your children, below 6 months, a birth notification. Above 6 months, you need a birth certificate as established by the law. Now, indeed, this is a worrying scenario. This is one of the things you need to move with speed and dispense with. Now, I'll go to the disease patterns and trends, and I did mention yesterday when I spoke here that when we looked at our database, majority of the indigents are ailing from NCDs. And from the prevalence, you can see acute upper respiratory disease, we had 6,600 cases, or 12%. I'm told of, all right. Thank you, sir. We have hypertension, we have protozoal diseases, influenza, pneumonia, general symptoms and signs, and other diseases of digestive system. What am I saying? As we implement UHC, there's something that is called health technology assessment. I know some of you have been trained on HTA. I don't know by a show of hands. Is there anybody who's been trained on HTA? Health technology assessment. Thank you, sir. HTA is the tool that informs the government or counties where they need to invest in resources. I want to share a little secret with you. Sometimes when I go back to the village where I come from, I hear the county administration led by our governor saying that they have attained universal health coverage. And when they speak, they say they've set up a state-of-art dispensary. That is UHC. I want you to go back and tell them UHC is preventive, promotive healthcare. Are we together? So that we do not mislead the public that infrastructure, which is a key component, is UHC. And that is why I want to appeal to you. Some of these ailments, the upper respiratory diseases, hypertensive diseases, lifestyle diseases, can be arrested before they occur. And you heard yesterday, 1 shilling that goes to preventive healthcare will save you 8 shillings that will go to clinical intervention. So from this, and Prof will tell you from the school where he teaches, that there is need to invest in preventive healthcare. Tell our people to drink boiled water. Tell them to sleep under mosquito nets. Tell them to eat healthy foods so that they do not get these lifestyle diseases. If you look at the top 20 reimbursed facilities in the 9 months, there is hope. And I want to say, indeed, UHC is real and we are making progress. Before UHC came into place, the bulk of the refunds that we used to make to healthcare facilities used to go to private and faith-based institutions. But from the data that we harvested in September, the bulk of healthcare facilities are government facilities, starting with Kenyatta, Moi Teaching and Referral Hospital. We have Rift Valley Provincial General Hospital, Makueni Hospital, and many others, which tells us Kenyans are acutely aware that if they want to access services without catastrophic out-of-pocket expenditure, then government facilities are the facilities of choice. I'll jump that service point, which I'll mention on later. I'll go briefly. There's something I wanted to take you through. Allow me, there's something missing in these slides, but it's all right. Now, For the inpatient benefit package, we have paid in excess of 1 billion shillings. And the billion shillings has gone towards inpatient claims for the 9 benefit package. When you look at it, the key cost driver has been, number one, medical inpatient. And when I say medical inpatient, when I look at the data, sorry, this thing has an issue. When I look at the data that we have, I note that apart from medical inpatient, we have renal dialysis. And when I look at the detailed report, which is not here, I noted that the counties in Mount Kenya have a big challenge of NCDs. Who comes from Mount Kenya? As you go back, kindly tell your governors that you need to put into steps preventive measures for chronic ailments. We have a high disease burden when we talk of cancer, end-stage kidney disease, hypertension, diabetes, and many others. And as we finalize, this year when I'll be sharing the detailed report because the contract terms are ending in the next few weeks, I'll be able to share reports that are specific to each individual counties. The other thing I want to tell you is that going ahead, as our custodians, the link person between the national government and the county governments, we need to appeal to you as you go back, because we are starting the UHC scale-up. You heard yesterday the PS indicate that we have been given additional monies. Did you hear? We got 6 billion in the previous year. In the current financial year, we will be getting 9 billion, which means that apart from the 1 million indigent we covered in the previous year under review, this current financial year will cater for 1.5 million indigent households. So ensure, I'm winding up, that you back up front. To be forewarned is to be prepared is to be forewarned. By now, as you live here, kindly activate the community health workers, work closely with the State Department Social Protection, continue identifying indigents for the scale-up, because we are starting the scale-up in the next 3 weeks. When the circular will come, when we'll be requesting for indigents, work closely with the NHF offices so that you submit on time, so that we don't end up missing the mark by a wide margin. Let me mention something on the outpatient benefit package. As I sit down, we've been able to pay capitation for 4 quarters, ending December. By a show of hands, kindly show me whether there's a county that has not received its capitation money. For the 4 quarters, we paid 2 weeks ago. And we paid in excess of 600 million. I can see there's deafening silence. Now, for the entire financial year, we have paid 1.6 billion for the outpatient benefit package known as capitation. The $1 million question that we get in our offices is that sometimes that money does not necessarily translate to quality of care. And I want to challenge you here today. As you take the 1.6 billion that we've paid this current financial year, it is your duty to be faithful stewards of the money we've paid to ensure that these indigents get value for money, because sometimes they do write and say that they've been told to buy medications. With those very few remarks, I beg to rest it there. I want to thank the counties that have partnered with us. Moranga County, who recently onboarded 20,000 indigents. We do have Kiambu County. We do have Kisumu. Thank you, Uganda. They sponsored 21,000 indigents for the next financial year. We have a long-time partners in Lamu. Daktari, kindly thank your governor. My appeal to you, we have about 5 counties that are on board. Where are the 39 counties? In the fullness of time, when we'll be put on the weighing scale, what will we tell our maker how we didn't support the indigents? And true health is wealth. Thank you, and God bless you.
A round of applause. Oh, this guy is very brave.
Can we give him another round of applause? While he was actually presenting, the questions also already were flowing. So you already have some here. And you've heard the take-home message. Out of the 1 million indigents that the national government has given to the counties, and this was shared equally between the 47 county governments, there are quite substantial number that have not been captured, free money that we are losing. Then, there is also the one that is coming. So if we have not captured out of the 1 million, let's say your county got 20,000 or 21,000, and you have not captured, please go back and look at how many. How many people have been captured under what was allocated to Lamu, Muranga, Kisumu, so that then you can see what you can do. Get the number of Osoro, so that ile mtu ako NHIF huko kwa county akikuletea mastori mingi, you have got some refined information. Thank you very much. I know very many questions are going to come, but I want to also assure you that Mandera County is putting onboarding 20,000 indigents. So tutaongea baada hapo biashara. The next presenter is Dr. Helen Kiarie on county health indicators. And after that, we have got also one interesting session presentation after Dr. Helen. Dr. Helen is around? County health indicators, Dr. Helen Kiarie, she's not there? Oh, she's there. So as Dr. is coming and we're welcoming her, can we give her a round of applause as she comes? Yes, Daktari, as you come, mawaziri hawajaona maji jana, na leo pia itakuwa ni shida. So you can have a summarized version of your presentation. Thank you very much.
Habari zenu. I hope mmekunywa maji lunch, mnataka kunywa ya bahari. I hope you don't 15 me. Okay, fine. All right. Okay, thank you so much. My name is Dr. Helen Kiarie. I work at the Division of M&E at Ministry of Health. I was almost changing my mind about coming to present because there are so many complaints, about things that have not worked. But as our PS said in the morning, I think we are here to look for solutions together. So I'll go straight into my presentation. I'll not go into the vision and mission for the ministry. I think that one is known. But just to mention that the health sector is guided by a number of policies and documents. Number one is, of course, the Global Health Agenda, Sustainable Development Goals. We have the Universal Declaration of Human Rights. We have our Constitution. We have our Vision 2030. Within the sector, we have the strategic plan, and we have the universal health coverage and policy. I think a lot of these documents maybe will become clearer for the new executive members as we go along. Not in this presentation, as you continue doing your job. Okay, so within the health sector we have, and within the health policy, we have 6 main strategic objectives. Number one is to eliminate communicable diseases like HIV, TB, and malaria, to reverse the burden of non-communicable diseases or the lifestyle diseases, reduce the burden of violence and injuries, provide essential health care, basically maternal and child health, and reduce exposure to risk factors. In terms of UHC, I think we all know that in this space, we are really focusing on implementation of UHC, and really some of the specific indicators targeted is 100% access to medicines, essential health package, reduction of out-of-pocket expenditure. I think this is usually the biggest headache, people having to pay out of their pocket for health. Move closer to getting the optimal number of health workers, increase functionality at the community level of community units, people accessing healthcare, and of course all this framework, I think, as we have heard in by my previous, the primary healthcare strategy is really what is being targeted to, to strengthen implementation of UHC. This is just one out of very many things that are done within the sector. We know there's, the targeted implementation of primary healthcare networks, which is a whole presentation by itself, and basically strengthening some of the high impact interventions like, nutrition, WASH, maternal and newborn health services, NCDs, and also outreach services, taking services closer to the people, especially for counties that don't have enough health facilities, or people are not accessing health facilities for one reason or the other. So just to mention, the areas highlighted in blue are the facilities that are under the purview of the Ministry of Health or government. So we have about 13,000 facilities as at 2019. I think the number is more or less the same even now. As you can see, about 45% are government, which is about half, and most of them are level 2, the dispensaries, which of course, since devolution, a lot of dispensaries have been put up, and in a number of cases, many of them are not fully functional. So just also to emphasize, Kenyan population is mostly young, which means also, as you're providing services, sometimes we focus so much at the higher end of the pyramid, which has fewer number of individuals, but they have these high cost illnesses, of course the lifestyle diseases, and of course there are also diseases of old age. So maybe it's a good problem because you want people to live until they're dying of old age, and old age will come in terms of mostly cancers and all these things, but just to note that our population is mostly young, and we need to really focus on strategies that strengthen especially child health, adolescent health, and other things like those. So this is a very quick summary of progress of some of the key indicators that we are tracking as a health sector. So life expectancy at birth is actually the one indicator you can use to measure health, progress of health. And with high income countries like Japan, I think the US is not doing so well. You'll find that they have a very high life expectancy of over 80 years. So we have grown over the last about 10 years since 2013, around the time that devolution came into place. We have made quite some progress. Life expectancy has increased by 6%. Maternal mortality decreased by 31%. Which also signifies a transition of investments in maternal health to gains over the last 10 years. That figure there is in asterisks, is 249, because we had an estimate of 355 in the last census, but there were quite a bit of issues in terms of that data element, and we actually sat down with a number of experts, the Bureau of Statistics, Civil Registration, and other stakeholders, and we went through a very rigorous methodology and came up with an adjusted figure of 249 as the maternal mortality estimate for Kenya. And we hope to do that for counties next year, because the estimates for maternal mortality for counties also, some were not really aligning with what is expected, because some of these figures, really, there's a lot of contextualization of how you interpret them. So we intend to do that process early next year. So under 5 mortality, that is children at the age of 5, we have reduced that by 21%. So basically gains in child health, maternal mortality child mortality decreasing by 21%, and neonatal mortality by 9%. But the biggest gains were really made in infectious disease control, HIV/AIDS, which reduced by 72%, as well as incidence of TB infections, which reduced by 48%, but overall, all the indicators have really shown some progress associated with both devolution and the implementation of UHC. So we try to compute an index. We are calling it the UHC service index because a UHC index would ideally also have the financial implication, but it's really, even globally, I think people are still confused how to incorporate the UHC financial aspect into that. So as you can see, the UHC index over the last decade has increased by 21.7%, from 59% to 80%. So this index consists of three things: service coverage. So how much have we increased coverage of immunization, attendance, women delivering facilities, women coming to the facilities for antenatal care and such things. We also have access. How many people have a facility near them? So reduction in the distance to health facilities, increase in number of beds, increase in health facilities, and also and other things, and bed capacity. So how many beds do we have available for Kenyans? We also have quality index, which looks at, there are some specific indicators that monitor the quality of healthcare. As you can see, quality really, as much as we have gained overall in UHC, what we are doing well in is the service coverage. You have increased immunization, you have increased women delivering facilities, coming for antenatal coverage, but the quality of services is still low, and therefore we are underperforming in terms of overall UHC because of the quality of these services. So if you look at the county landscape, we find that this was lowest in Mandera. This does not mean these are the counties performing the poorest. It just means that this is where compared to the national performance is a bit low in Mandera, Trans Nzoia, and Wajir. Garissa, Kilifi also below the national score. So we have the top causes of morbidity. So just to emphasize that injuries and lifestyle diseases are increasingly becoming a common source of illness, while the communicable diseases are decreasing. So as you see, the blue bar is becoming smaller. The one in the middle, the orange or brown, is becoming wider, which means that non-communicable diseases are becoming a problem. Respiratory infections, diarrhea, are the leading cause of illness in children under 5. And I think that is also what our colleague in NHIF has shown, that respiratory infections are really an issue. Among over 5 population, including adults, respiratory infections and malaria are seen as a problem. So in terms of health financing, we are really performing below what was expected. So the sector needs to scale up insurance coverage, and I think it's good that our colleague from NHIF has really brought out the issues of insurance coverage. So at the end of the day, we have about 20%, as of the last survey, 20% of the population covered by insurance. I think we are due to do another survey. Maybe this will give us a better performance. Government allocation to health is still below the Abuja level. So we are allocating about half overall. And our population is really incurring a lot of what we call catastrophic health expenditure, where households spend more than 40% of their non-food budget on health. So in terms of human resource, a lot of counties are below 2023. If you look at the line on the left, a lot of counties are below 23 in terms of core health workers. We usually use nurses, medical officers, and clinical officers to measure the density of health workforce, or coverage of health workers per population. We can see it is high in Nairobi, but then in Nairobi we have many health workers, but if you look at the density, which is the diamond, Nairobi actually has a very low density of health workers. And in terms of medical specialists, again, general surgeons, obstetricians, pediatricians are really some of the very common specialties, while cardiologists, oncologists, neurologists are not common. Then we have, in terms of the strategic objectives, in terms of eliminating communicable diseases, we are doing fairly well, but malaria incidence is a problem. Immunization, we are doing well in most of the counties, but we still see some counties not doing very well. In terms of non-communicable conditions, we find that more NCDs are being diagnosed. If you look at the targets, we actually targeted higher. We didn't want more people to get sick, but we thought a lot of people are getting diabetes in the community, but they're not getting diagnosed until the last minute, which of course means they're likely to come with complications, ending up in dialysis and all that. So the interventions targeted more to identify these people. So we were able to identify just about what we had targeted. And we still see cardiovascular diseases, cancer, diabetes, injuries increasing. In terms of hypertension, we can see some counties are really having a high number of hypertension. Of course, these are just numbers. We have not expressed them into population. Oh, sorry, they're actually by population. So this is like a rate. So Tharaka Nithi, Nairobi, Laikipia, a high number of hypertension cases. In terms of maternal and child health, we have quite some progress in terms of deliveries in health facilities, which is good. But neonatal mortality and family planning, we are not doing very well. There's an indicator called maternal deaths in the hospitals, in the facilities. As expected, Nairobi will have the highest because of most complicated cases that are referred to Kenyatta. But we see counties like Siaya, Kilifi having quite a high number of maternal deaths. Overall, in terms of maternal mortality, this has increased slightly, unfortunately, as of this year. Skilled birth attendants, I think that one, most counties are doing well, but we still have some counties still having significant proportion of mothers delivering at home. I think in the detailed report, we also go further to analyze the most improved. You may find that some counties may still be way below the national average, but they have really come up in terms of over the last 10 or 5 years. We have also been trying to strengthen PHC. So we have the primary healthcare vital signs strategy, which is basically a tool that helps to shine a light on where systems are strong and where they're not. So there's a link on the Kenya Health Observatory that gives the county profiles, and you can actually select your county at the top right corner and see in terms of equity, coverage of RMNCH, catastrophic health expenditure, allocation of finances to primary health care and all that, you can see the profile of your county. So in terms of overall performance towards our strategic plan and SDG targets, there's some improvement in most indicators, but progress is slow. Progress towards SDG targets has been highest in communicable diseases like TB, HIV, but slow in malaria. Then there's in terms of premature mortality due to non-communicable diseases, we have a lot of data issues in these indicators, which we are slowly gaining mileage on. So it has been a bit difficult to track our progress on these indicators. And as you know, we are getting more and more into the NCD sort of space and burden. Then reduction of maternal mortality and child mortality is low, and we are unlikely to meet the SDG targets if there are no acceleration plans to improve especially quality of care. We need a multi-sectoral approach in reducing risk factors. So some of the major gaps that have been seen, of course I'm just highlighting really very few things. Weak primary healthcare systems to serve vulnerable populations, health systems challenges, health financing, sustainability, prioritization of high health needs, suboptimal quality of care, frequent stockouts of drugs, and in many cases, lack of data for decision making. Of course, the issue of multi-sectoral and intergovernmental collaboration, I think, has come out, and this is an area, of course, that needs to be strengthened if we are to make progress in improving the health of Kenyans. Okay, I don't know whether it knows. Okay, so some proposed actions by by yourselves. As we know, strengthening healthcare financing is key. So NHIF, of course, is really key to reduce out of pocket. So issues of advocating, advocating for uptake of NHIF by almost everyone, investing in equipment to do the transactions, NHIF transactions, ring-fencing of health funds. This has been an issue. I think the issue of strengthening service delivery has come out. Low quality service delivery is an issue. So there's need to strengthen even the community units, the primary care networks. I think this is key. They need to equip primary care facilities. In some assessments we've done, you find even a facility having one glucometer, the machine that is used to take sugar, or even like a stethoscope. So these small equipments, they are very key and useful in strengthening primary health care, equipping the labs, of course, and the drugs in primary health care facilities. Things like support supervision, implementing the Kenya quality model of health. I think these are low-lying fruits. Of course, coordination through intergovernmental forums. There are technical, thematic committees that are outlined in the partnership framework, and also following up on agreed actions. I think for HPT, let me not get into that discussion. I think that one is already somehow being addressed. Of course, building a strong human resource is key. Making sure that cashiers are paid, strengthening recruitment, deployment, and performance management of health workers. I think at the counties, there is need to scale up research, HIS and M&E. I think in our M&E guidelines, we actually have an SOP, a standard operating procedure, or a guideline on how to establish an M&E unit. And this is really useful because in counties where we have M&E units, things really work fairly well. Promotion of electronic medical records. That's the end of my presentation. Sorry, I think it was hurried, but thank you.
Thank you very much. A round of clap for her. Iyo haikai kama ile imekula lunch ya samaki na kuku na beef and everything that we do. Can we repeat? Fantastic. Thank you very much. Now we have got the last Kabisa presentation on technology. Something that was presented to Excellency Governors when they came to Mombasa. And it is through their advice that we are also advised to look at it as County Executive for Health. So this is about Zipline, a technology, a drone-based technology that Dr. Ganda from Kisumu is very much familiar with. So let's hear from the presenters, and then we hear from Dr. Ganda, so that then we see how to digest and maybe uptake it. So, yes, you are here. Karibu sana.
All protocols observed. Good afternoon. They say, thank you. I'm always complaining. I'm always given 10 minutes. Thank you for the 15 minutes today. I guess he who laughs last laughs best. I hope it will be worth the wait. So my name is Winfred Njeri, and I'm the country manager for Zipline Kenya. Okay, so here we are. So Zipline is actually a logistics company. When we started, We were known as a medical company because we launched in Rwanda in 2016. Most people actually know us from Rwanda. They always say, Wale watu wa Rwanda. But actually, we're actualizing it now here in Kenya. So we're a logistics company that launched in Africa, headquartered in the US in San Francisco. But our first operations were actually in Africa. And our mission is actually to provide every human on Earth with instant access to vital medical supplies by use of drones. So we are used to the normal traditional way of distributing medicines and medical commodities, which is a big truck, of course the motorbikes, all the other road transport. But Zipline actually is, the drone technology is it uses what we call aerial logistics. So it's actually highways in the sky. Think about it the way we have highways on ground. So we are creating highways in the sky, that these highways, they actually come from our hub to each and every facilities in the different counties that we're going to work with. Sorry, I'm learning it. This is, okay. So this is the footprint we have in Africa and other parts of the world. We are actually the only drone company in the world that operates at a commercial scale. And recently, as if some of you have read, we actually won the best drone services in the world when it comes to aerial logistics. So this is our footprint in the last 7 or so years that we have been operating. Our first operation was actually launched in Rwanda. And in Rwanda, we have 2 hubs. And these 2 hubs are able to serve 90% of the country, delivering blood. Actually, outside Kigali, all blood is delivered by Zipline. And so we have 2 hubs that are adequate for the whole country. And from Rwanda, we expanded to Ghana just at the onset of COVID. We were actually launching in Ghana, and now we have 6 operational hubs. Hubs mean like they're actually in different regions. For example, in Kenya, we can say we are in, let's say, 6 provinces, something like that. That is 6 provinces in Ghana. And we are launching 2 more by March 2023 to make them 8 so that we're able to cover most part of the population. We are launching soon in Cote d'Ivoire. Actually, next week we should be launching our first hub in Cote d'Ivoire, but next year we have 3 more hubs coming up. And of course now in Kenya, where we are ready, set to go. Tomorrow we are hoping to get our right to fly from Kenya Civil Aviation Authority, and we can start operations anytime from tomorrow. We shall be gracing the skies with our drones, providing critical medical services and of course saving lives. And then we actually now also have 3 hubs in the US, Utah, Arkansas, North Carolina, and Japan, where we serve over 400 islands. Nigeria, we have now 1 operational hub in Kaduna and launching 6 soon. And the last one actually that is not here is Ukraine. We did launch Ukraine in April. You can imagine now with the war crisis, a lot of areas are cut off from supplies, and Zipline just launched their operations there. So that is our current footprint. And with all this, the number of deliveries we have done, we've done over 400,000 commercial deliveries all over the world. And we have done both routine and COVID vaccines, doses of over 7.5 million plus. And then, of course, over 150,000 units of blood delivered. And then we serve over 3,400 health facilities at the moment. So this is how Zipline looks in Kenya. Our first hub is going to be in Kisumu County. It doesn't mean that it's in Kisumu County. We only serve in Kisumu County. I'll show you how it works. So we build our operation hub in Kisumu County, where right now we have built it in an area called Chemelil, where we now do the drone operation together with the storage, the centralized warehousing. And from there, we are actually going to serve different counties. You can see 80% of the health facility will be across different counties: Kisumu, Kericho, Nyamira, Vihiga, Kisii, Homa Bay, Kakamega, Nandi. Actually, we're even about to we can cover a bit of Nakuru, like 30% from that hub. But at the moment, we are still trying to see these are the ones that we can completely cover right now very confidently. And I will explain why we are only covering that for now. And this is how it looks like, our expansion plan. It looks like this. As we launch hopefully this year or early next year in Kisumu to serve the various counties at the Lake Region Economic Bloc area. We are hoping the next distribution center, this is how we are planning to expand in the next 2 years. So maybe the next distribution center will be in Elgeyo Marakwet, for example. It's been mapped there. It's going to serve Turkana, West Pokot, a bit of Baringo, Busia, Bungoma, Uasin Gishu, the Elgeyo itself, and that and Trans Nzoia. And that is how we keep expanding. We're going to serve the coast. We're going to serve the Mount Kenya region. We're also going to come towards Kajiado. So this is how we're actually planning to expand so that at least the whole of the, at least we can increase access of medical commodities and essential commodities to most of the population in Kenya. So this is how it's done. We actually do what we call, we build a state-of-the-art warehouse with both, which also includes cold chain, pro cold chain facilities. So we're able to store all medical products or medical components in our warehouse. And we do what we call track and trace from inventory management when we get the products, whether from the regional medical stores or whoever is giving us the supplies to centralize and warehouse in our warehouse. We do data management from inventory, warehouse management, and also at the end, we do track and trace. In some clients, we even invoice if we needed to invoice, and of course, report that back to our clients. And this is how it works in summary. Then we'll play a video just to put to bring the theory to practical so that you can be able to get a better mental picture. So a health facility calls Zipline. For example, here, an agrovet, because we do also animal health products, or a healthcare worker calls Zipline, for example, at 8 a.m. In 5 minutes, we are actually fulfilling that order. We are packing it. And in the next 5 minutes, we are actually putting it in the drone, and the drone is being launched. And depending on how far the facility is, the maximum distance of the facility should not be more than 45 minutes, which is like 100 kilometers. The farthest will be 8:40 a.m. Coming as in 40 minutes from our hub, and it will be coming back home at that particular time, and it will have been delivered in 25 minutes. So that is how it works. But now we've reduced the fulfillment rate from, we've reduced it from, sorry, I have to go back there. We've reduced it from 8 to 8:05. We are actually now doing 3 minutes. From the time an order is placed, in 3 minutes, the drone is in the air. Just to tell you how fast it is. So this is the drone that does the work. Sorry, this is hanging. So this is how the drone looks like. So our drone serves 200 kilometers radius, meaning it goes one way, 100 kilometers, and returns 100 kilometers. And the maximum load right now is actually 3 kilos. This is just a new addition. We were actually doing it up to 2 kilograms. Now it's 3 kilograms with a new package that we have come up with. And it flies 400 feet above ground level, meaning there's rare interactions with manned traffic. And we do hundreds of deliveries. For now, our busiest hub in Ghana is doing 400 flights a day. So I can imagine in Kenya how huge that will be. So it's quite a very, very busy operation. We fly on all weather, whether strong winds, heavy rain, extreme temperatures. If we have an emergency, you need blood, a mother is actually at the surgery table or delivering. Whether it's raining, for us, we actually fly the drone, and it's going to get there in 10 or 25 minutes. We have zero emission transportation because we use powered batteries, electric batteries. And of course, we are equipped with what we call automated detect and avoid. This means we're able to detect, let's say, a helicopter during our operations. And of course, we have best-in-class safety standard, and that is why we've been able to operate in so many airspaces in the world. I want us to play a video now. Play video 1. Just to give you a day in Zipline, how it looks like. On the flash, it's called Ghana something on the flash. Video 1 is on your email. Sorry. As if name Ghana on your email, it's video 1. On the flash disk is Ghana video. sorry, as they get the video, I can continue. I never want to go beyond here because there's always a lot of mental questions. Okay, so you might wonder why aerial logistics, why zipline? One of the things that we, like I said, our aim is actually to ensure that there is equity in access of medical products, meaning that it doesn't matter where the facility is, where the facility is situated should not dictate if they receive products or not. Most facilities that are in the city center, yeah, I think there. Sorry. Okay, just rewind it. This is a typical day in Zipline, and this is exactly what we have in Chemelil. This is one of the hubs in Ghana. So you can see she's receiving the order from the facilities, keying it in for the packer. She goes to the fridge and gets what has been ordered. In this instance, it was blood. This process, like I said, is 3 minutes. Just so the video is dragging, but it takes exactly 3 minutes. So normally they do the fast checks, and that's why in our hubs, they're run by medical professionals, whether lab technicians, pharmacists. They just do a physical check, weighs, because like I said, we don't fly beyond 3 kilos, so they have to weight, and if it's less than 3 kilos, we use water blasts to support, to add a bit of the weight. And then it is packaged with a very, you can see it's a special kind of packaging, and we wrap it 8 times just to retain the integrity of the product when it gets to on the ground. This is actually cold chain transportation on air. So when she's done, she gives it to the flight operator. Flight operator checks the box. You can see the box has a small barcode. That is the ID that tells the drone where that package, which facility it's going to go. Before that, of course, we've already mapped all the facilities. We've gotten their GPS coordinates, and we know where the package is going to drop in the exact location in the facility over and over 1,000 times. It never misses its spots. So the spot doesn't change. As you can see, the drones are light. It's actually made of styrofoam and fiberglass. The only heaviest part of the drone is actually the battery. So the operator puts it on the launcher. You realize our drones don't take off. We actually catapult them. And they have different segments. This is the wing, and then we had the body of the drone. And why our drones are in different segments, so that in case, let's say, for example, the wing is not functioning, you don't ground the whole drone. You just remove the wing and replace it with another wing. And the same goes to the battery. You can see the batteries are charged electrically. So he puts the battery on the drone. Does physical checks just to ensure that everything is on it, it's okay. And then you'll also have where he uses a mobile phone with an app to check that it actually, the drone will tell you if every part of it is safe to fly. You can see the lady, that's what she's doing. Those little codes tell you if every part of the drone is set to fly. I know some of you have been to our operations center, so this is sounding like music. It's quicker than this. And if the drone is now ready, it is launched. And it leaves and goes to the health facility, where it will go and do a drop. The last video will show you how it does the drop. You can see how it flies in the skies. It has the little light, so you can actually not see the drone during the day, very rare, but at night you might see it. Then it comes back home, it doesn't land, it's captured on air, and it reduces its speed. Actually, the landing part is always the best part of it, yeah. I can see the reactions. Even when you come on site, it's the best part of everything. So it's coming back. You can see it from a different angle. We can play the last video, and then I just finish. Video 2. On your email. Zipline, it's on your email, it's not here. Anyway, as he gets it, as I was saying, our partners, how have we used drone technology in other countries? We've used it not only for human health, but also for animal health. Like I said, imagine all the facilities where there are as many farmers in those primary healthcare facilities, which surround those primary healthcare facilities, and we deliver, okay, we can do the Africa impact, but it's not the one I wanted. Sorry? Sorry, guys. Oh, okay. I think that would have been a better video. Let's see which one we can do. Okay, we can play that one. Play that one then. I wanted one that was specific to Africa, but this is literally for everywhere. So we've been able to use this technology for both human health and animal health, like I said. And for example, now the counties, we're going to serve both animal health and human health. In animal health, we actually do delivery of vaccines. We do delivery of artificial insemination products like bull semen, swine semen, right to the farmer. At the time the cow is on heat, you can imagine that is where they lose productivity when they have to wait for long, but this is actually for a meeting with the CECs of agriculture and livestock. Let me not go deeper into that. But also we are using it for e-commerce. In Ghana now, we are actually piloting with Jumia to do e-commerce where we deliver we deliver actually personal consumer goods to their homes. And we're hoping to launch this in Nairobi in the next 2 years. But now we're only starting with the human health aspect of it. If you think about products that need to be centralized, what aerial logistics does, as Zipline, we've seen the impact, is actually reducing of wastage, reducing of that people ordering what they don't need because they don't know when the next stock is. So we do what we call emergency deliveries, like blood, oxytocin, all those things, insulin, but also anti-rabies, anti-snake, volume. Technology. I'm in technology, so I'm disappointed. It always disappoints me. Oh, it's the internet. Okay, I don't know. Yeah, so we centralize. For example, like I said, in Rwanda, we deliver all the blood products. I think let's just leave the video. It's all right. It's okay for now. Can you hear? They can't. It's okay. Give me 1 minute, I just go and help him. 1 minute.
While she's sorting out, can we stand up and stretch? I will not do big ones like Hadra, so we'll just do small ones. And we stretch. On the left, to the right, a bit behind, stretch forward. Yeah, I think this is okay. We are just left with probably what she's going to present. We can have a seat. The moment we are done, very quick session of plenary, and then we'll be good to go. I think our timing is not bad. I can see Professor Mwanje is ready for the splash. While she's sorting out, maybe the panelists can come huko mbele, and we can start with the famous Osoro. Tafadhali, Dr. Helen, Robert, you can take a seat. I'm sure itakuwa dakika moja tu, utakuwa umemalizana. Technology, eh? I'm very sure the drone will not fail. Ni kidogo tu ya hapa. Na utatuambia kwa nini huko Mandera na North Eastern hakuna kitu yote umeplan. Utaki kuja?
A lot of people look at what Zipline does and assume it's total science fiction and it's a decade away. But the reality is actually it's ready today. There's an opportunity to build a totally radically new kind of logistics system for the planet. We wanted to build the first logistics. A lot of people look at what Zipline does and assume it's total science fiction and it's a decade away. But the reality is actually it's ready today. There's an opportunity to build a totally radically new kind of logistics system for the planet. We wanted to build the first logistics system that would serve all people equally. The idea is simple. The technology required to do it is complicated.
What Zipline's experience has taught us is that the technology is ready, right? We're able to serve people today with the technologies of today.
If we want to make instant delivery scale for every person on Earth, we need to be doing that using small electric vehicles that can be operated autonomously and that are 10 times as fast as traditional logistics.
The drone is certainly the most visible part of what we do, but there's a whole set of technologies we developed that really enable us to do what we do. This ranges from software we've built that enable the regulators to oversee our aircraft in their airspace. It includes sensing technologies to sense other aircraft and avoid them, route planning software, weather forecasting tools.
It's one thing to create a product that works the way it's supposed to every time. It's another thing to create an operation that works the way it's supposed to every time. And that's from start to finish, from how the product is designed, manufactured, flown, maintained, and then how, at the end of the day, provides a service to a customer. And at Zipline, we do all of that.
The current system can deliver basically 100% of medical products and almost 85% of traditional packages just moving through e-commerce. Any of our partners can pull out the phone, press a button, and instantly request an autonomous instant delivery of a product that they need.
That order goes out, gets put into a zip. The zip gets put onto a launcher. It's launched, and now it's flying autonomously out to the delivery site. When it gets there, it drops the package from the air. The zip turns around, flies back, lands, and is ready for the next zip. And at any given time, we have dozens of zips in the air doing exactly that to different parts of a country.
Countries that have shown initiative and using it to transform health systems and totally change the way that their national infrastructure works.
Welcome to the fulfillment operations area. You have medical products stored, the blood products are stored, where the vaccines are also kept, and where the products are generally packaged and sent across to the health facilities. Across the country, we serve 1,600 plus health facilities.
It's very difficult for rural areas to store critical medical products on site. And so what we are doing in Zipline is to ensure that the supply chain is revolutionized into a system that is very responsive to what is actually happening on the field.
5.5 million children lose their lives every year due to lack of access to basic medical products. The technology has gotten to a point where there are no more excuses. You could put every single person within the country within 15 to 25-minute delivery of any essential medical product.
Being able to make the supply chain so responsive so that they can vaccinate children against some of the killer diseases and people can receive that same quality of care wherever they are, it's very impactful to see.
It has changed the system for us for the better. We are 100% sure of product availability. Even when there's shortage, plans are in place to cover the whole country, so that every single facility in the country will have access to the right commodity at the right place at the right time.
Having operated for as long as Zipline has, we wanted to be thoughtful in how we lead so that not only can Zipline be successful, but the industry can be successful.
As Zipline has brought our autonomous instant logistics to the US, we've been pretty excited to see that there are some big companies and health systems in the US who share our vision for what instant logistics can mean at national scale.
If it's the middle of the night, you need a thermometer, you need
time, we've had to cut the video. I know we have so many questions. Maybe we'll have it after the panel. But that is in short what Zipline is and the impact it has had in the countries that we have served. Ensuring that there are no more excuses. There's no more telling the patients we don't have the drugs. You can actually tell the patient, just give me 5 minutes, I'm going to call Zipline, and your drugs will be delivered. Thank you.
Thank you very much. I think you have heard loud and clear. I'm sure there are questions, so you can just come up and there will be several questions. That I'm very sure. Dr. Helen, please, just at the plenary session. Robert, first presenter, please. May I start with this first question that came while you were presenting, Mr. Osoro, NHIF and HIV and AIDS. What are the plans to include HIV/AIDS as part of what is covered for persons living with HIV, which is a chronic condition? What are the barriers or challenges? Can a scheme approach work? That came. Maybe you can just hold and take the question. Then, is there any mic that is going around? Please. Let me start from the middle. Every time it comes from corner first. So let me identify Dr. Ganda. Then, okay, jirani hapo. Wacha tuchukue mbili kwa kila mahali. There. Okay, Javan. Then, huku kwa kina Khadra hakuna question nafikiri. Okay, Khadra 1. Behind 2. Then, this side I can see there are many hands. Okay, I'll give all the 4 of you. Can we start with Dr. Ganda?
Yes, thank you very much. I'll be very brief. My question goes to my friend from NHIF, Mr. Osoro. What can NHIF do to increase the insurance penetration? The one-size-fits-all that you must pay 500 shillings or none actually leaves out a very big percentage of people. And some of us believe the Makueni way. Makueni has a program where people pay 1,000 shillings per year to get primary health care and some bit of secondary health care. And they're planning to increase this to 200 shillings per month. My colleagues are in Rwanda today, and Rwanda has done marvelous work. That's where they came up with the drone. They're talking about insurance penetration of 89%. The insurance does not cover many things. There are no big things. You will not go out of the country. There is no cancer. There is no kidney transplant. But they have covered 90% because it is cheap and can cover all the primary health care. And that is really the essence of UHC. So my questions to NHIF, is NHIF so fixed that it cannot, for example, help Makueni with Makueni care, that you can still pay 200 shillings per month and you manage the fund for them. And so NHIF becomes a fund manager so that we're able to reach the people who can pay less. And maybe in the next 5 years, maybe, then see how you can bridge that gap. But at least everybody should have some insurance to begin with. Thank you very much, Njeri, for the presentation of Zipline. One of the things I want to say about Zipline, and again, it came from Rwanda. Rwanda is serious and makes decisions. I've had mothers die just 40 kilometers, 50 kilometers from Kisumu because of blood. You're in theater, there's no blood, and so you try to pack the woman and put her in a matatu or in our ambulances to try and transport her, and she dies. Sometimes you have an operation which cannot be done. You have a theater, you have a doctor. The anesthetic says, I'm not comfortable because the HB is 8, and so this emergency we will not do. We will pack you in a vehicle and send you somewhere else. And so for Kisumu, I think we took the risk. The governor was brave enough. This thing had been there for 5 years, even before Njeri. And when he had this, we said, we are going to do it. And I think that's why probably we started from Kisumu. But this cannot be a platform used by a single county. The cooperation costs, I think, are a little bit high and requires us to merge together. And so the blocks will have to start thinking of how do we hold each other as blocks and buy these packages as blocks. Or do we, in one point, decide to buy off? Because I know some countries, I'm told Israel or something, has been able to buy a hub. And so they lease, they tell Zipline, run this hub for us, but it is ours. But you see, 500 million might look a lot of money. I don't know what the cost is. I'm guessing a figure. But if 15 counties came up together, 500 million becomes a small thing. It becomes 50 million, and we have it as ours. I've not said 500 million is the cost. I don't know what the cost is. Maybe it's 100, maybe it's 200. But holding it together can give us better returns. In Rwanda, they're so organized. It's not about actually the drone. It's about the organization about the drone. That you can predict who is going to donate blood next year in January 16th. They have planned it out all together, all in advance, and that's what makes their systems click. Thank you very much. I said I'd be brief, but I ended up.
Very good. Yeah, next.
Thank you. My question goes to Mr. Osoro. You talked about sending us some reports. Just in the era of transparency and technology and accountability, is it possible that you send to every county, like now in Busia, tell me how many people maybe, which hospitals got capitation, so that we have data that you can always refer to. And you know, we are going out now to start recruiting them. So just like a report card, we'll be encouraged if you see that you're doing much better every year. So maybe that can also be factored into the reports you send us. The hospitals where capitation was sent. So that comes to the CEC, so I'm more informed. Because as you asked, you saw no hand went up. We know nothing about this capitation manenos. Thank you.
Thank you. On the other side.
Thank you. To Osoro, and I think mine may just be comments and requests, not questions. Ndakuuliza yingine kwa tent kando. Now, she asked what I wanted to ask, but just to add some weight, please, having worked with these kind of interventions, the UHC, somewhere where you know, we really ask for more information. You realize facilities are incapacitated. When you go around asking them, so how much were you supposed to get? So how much did you get? They cannot give you those kind of answers. We would like you, being who you are and very important partner, that you make information more accessible. We will appreciate having a dashboard, the way my sister shared a dashboard, that I can zoom into my county, my facility, as quickly as that, and we can get this information. So I'm actually going to request that for the presentation that you made, are you able to share, for example, for Elgeyo Marakwet County, for West Pokot County, so that we feel it better? These things work better, politicians listen to them better when we can disaggregate data to units that matter to them. Like the MCA, if I show the MCA, Wadiake is doing worse than this one, they will feel it better. They can be willing to fund me better than when I speak about the national coverage. So we are asking you to disaggregate your data and bring it to a level where it's just a click of a button away. Number two, the timeliness of your payments to the counties, it is quarterly. One of the things that why people surrender very early is that yes, they pay, they come to the facility next week, there is no medicine, and they will not pay again. And the reason why we are not able to pay or prepare is I have to wait for 6 months. And yet I'm relying for the same capitation to prepare myself. We know we've had resources are a problem. So if we can make it a little frequent, I don't know why, what would stop NHIF paying more frequent, like on a monthly basis, so that it can be as useful. I think basically that is, lastly, on the UHC. I know it's an opportunity that we have squandered. You have 20,000 households, the people who are covered are only 20. You have your, what you showed, an M+1, the average household covered, M+1.3, 3 members, and yet we know the average household in this country is 5. That says there is something usually wrong. And so we want to correct that. I want you from where you stand to kindly advise us. How can we do it better this time round so that we don't miss out? So that we are not just talking about the spread, but the depth of cover. How can we do it better? Let me leave it at that. To zipline, thank you. That is revolutionary. Please welcome to my county. I can already give you a few 1 acre or 3 of land if you need. Lakini wewe kuja, kwa sababu that's where I need it most. We have snake bites, so that is instant. We have a bad terrain. We have conflict that sometimes results in a lot of injuries that need surgeries quickly. And so please welcome. So I have talked to him. Don't come to Eldoret, come to Elgeyo Marakwet. I have discussed with the CEC.
Okay. Waziri, penda jirani yako pia. So
yes,
Dr. Ganda said to cost cut, you need a number of counties coming together.
Yes, thank you for the presentation. Jerry, let me start with you. I think we discussed this, and I think we were in agreement that this is very good for areas with terrain problems, transport problems, and if you can do that, I want to agree with Dr. Ganda that counties should be able to create synergy and be able to put money together so that you can even achieve economies of scale in this project. As for NHIF, I think the biggest problem we have in Uasin Gishu County is that we don't know when the money is coming. Our people are not in the picture. We are unable to know. People pay. So really, like you said, we can see you on the side, because I think instead of wasting all these people's time, I think I will see you, because the issues of NHIF in Uasin Gishu County is still really very far. Thank you.
Very well. Thank you very much. Javan, then we come to this side. So, Javan, Tana River.
Thank you very much. Mine will be very brief and specific to zipline. The presentation was very good. In fact, when you look at it from point A to Z, the only thing that you can say is, yes, we want it like yesterday. I'm sure there must be some challenges, bottlenecks, some stuff that will make us not easily move there. Even even as we appreciate country Rwanda, because Rwanda, I think, has really decided to be an exception, particularly in Africa. Decision making things work very easy for them. But we know the challenges that we have in Kenya, and specifically in my county. What could be the bottle? What could be the challenges? Because even as I go home, I really want to sit down with my colleagues and carry this message. But I'm sure cost implication will come in. How much? How is it? Can we afford? Number two, are there any other challenges? Are there any hidden things? So I think maybe not only looking at the good side, can you open the other side so that you can also appreciate?
Thank you very much. Over to Quadra. We'll come back for you because I had...
Thank you very much to our panelists. My question goes to Osoro. I know when we started registering indigents, you are working closely with the 47 county government, the CECs for health, the directors, and also social protection. So now we are having issues. I just got a message this morning that counties should be able to actually report back in terms of data, because they are also trying to see how many patients have been covered under that indigent, because it is also telling them, giving them decision on UHC, because there's already budget cut because of data. I know as NHIF, you always get feedback because you are doing reimbursement based on the data that you receive from the counties. Where did we miss? Why are counties, why is Ministry of Health saying they are missing data? Because I thought by the time they should be reimbursing you, that they are giving you that money, it is NHIF who should be very accountable, but based on that data that you've received also from the counties, you've already reimbursed them that money. So where is the disconnect between NHIF and the Ministry of Health and the county government? Because I really want you to work closely, NHIF to work closely with the counties and feed into the data system. And that is why I know what Jalo was emphasizing on the issue of having, a system that everybody can be able to log in.
Thank you. Waziri behind there. Yes, the colleague there.
Mine goes to Dr. Helen. I'm one of the people that were very uncomfortable with the mortality rate. It's good it has been adjusted, but my question is, this adjustment, is it based on the fear of us acknowledging that we haven't made good progress?
Thank you. On the last line. So there we have got 4 hands.
Thank you. My name is Alex Leshenka from Kajiado. My question goes to NHIF. Well, the greatest partners, NHIF, you have are county governments. And in this sense, my question or rather comment will be, how can you use your regional offices to capacity build officers in county government handling NHIF matters, because already we are not even claiming what we are supposed to have been claiming, because the officers are handling that mandate are not familiar with how claims are done and all those kind of stuff related to NHIF. And with the phasing out of donor funds, the only reliance we have as county governments is NHIF, and therefore we must get it right, and we must work closely with county government, and even in areas where you decide to pay capitations or other funds, you'll be courteous enough to inform the office of the CC so that we act on ring-fencing that money into that various facility. We still also have a lot of issues to do with accreditation. There are certain facilities we discussed yesterday. There are certain facilities in rural counties like Kajiado and others that are still not accredited. And a number of them are still also lacking coding and all that. So that is my question. Thank you.
Thank you.
Thank you very much. Dr. Mbati here from Nyamira. I think 2 questions. One goes to our sister, Winnie, on Zipline. That was a very wonderful presentation, and in terms of shipping and everything. But my question is, what is the cost of shipping vis-a-vis the return on investment? Because we are going to invest, so we want to understand, because we said we are the ones who are going to advise the governors. Governors will sign this document, but when things don't work out well, we will be sacked. And we don't want to go that direction. Secondly, we have counties. I understand my brother here, who comes from Kajiado, has a vast county. I come from Nyamira. My county is not really vast, but our population is quite huge within. So what do you think, what is the value of me, Nyamira, picking it up when my vehicle can easily run across? But for this one, maybe it's possible because Kajiado covers from this corner to the other corner. So that's one area that I was looking at. Number 2, on NHIF, my brother Osoro, the area that I've been looking at is we have quite a number of programs that are being covered. You'll find a household has NHIF cover of the one they are paying 500 shillings. Then there is Linda Mama, and there is Eduafia. All these are in one household. And with this fragmentation, are we getting value, or why don't we then pull together? We pull together so that we don't fragment in terms of services, in terms of whatever that we are offering. Because you'll realize somebody comes to the hospital, comes to the Nyamira hospital, he has an NHIF card, but because they have come in pain, this mama has come in pain, we'll just admit on Linda Mama and start managing the patient. And the son will come, and the daughter, and such like. So this is an area we also need to look at so that we manage our NHIF well. Thank you.
Thank you. Next, I think, Caroline, I was seeing your hand is up. You're done? Okay, Dr. Mbarak.
Thank you. My question is to Madam Zipline. Part of the question has been asked by my Tana River and Nyamira counterparts about the cost implications, but I also wanted to know about the commodities. I saw in the video like one of your officers, picking blood from, right just next to their office. Do you have your own commodities, like the county just makes a call, supply blood to facility X, and you do, or do you take the commodities from the county? The other thing is, if the issue of costs is user-friendly, I will urge you, I've seen from your plan of rollout, I think you will reach Lamu in 2050, if the map is anything to go by. And there is a place called the Boni Forest. I don't know if you've heard about it, in Lamu. There are people living just next to Boni Forest and towards the border of Kenya and Somalia. And such a technology would add a great value, to such areas, because we want to revive the facilities that are around that area. I also know of Tana River. I worked with NASCOP in Tana River, and I know during the rainy season, there are a lot of places that are inaccessible. So perhaps you are doing Kisumu and part of Western, then maybe you can jump to Lamu and Tana River, and then go back to the areas of, that need it less, so to speak. Thank you.
Okay, I think the panelists can answer those first round of questions. If there is one or two that is remaining, we take in the second round. We can start with the man of interest, Mr. Osoro.
Thank you indeed. There have been a number of questions that have been asked. I'll try to respond to all of them. I will start with the first question that was raised by Dr. Ganda on insurance penetration. Indeed, it's a matter of concern that penetration in this country is very low, at 20%. But all is not lost. As I did my presentation, you noted that in the last 5 years, there's been a steady increase in the number of people joining NHIF, partly driven by the government through the Vision 2030 flagship projects, that is the health insurance subsidy program, orphans and vulnerable children, older persons and persons with severe disability. We have partnership with some counties like Lamu, and we appreciate Kisumu and others who have sponsored indigents who are poor and vulnerable. We have the national government constituencies. And I want to salute Coast Region, because in Coast Region, it's the only place whereby all national government constituencies have sponsored indigents across board. My appeal to you, as you go back, when you meet your members of parliament, and I'm told they've started getting CDF, kindly remind them that the functionality of sponsoring indigents is not only based on the national government. As Professor put it, healthcare is our business, and we must get out of our way to ensure that we complement the government effort. Now, we appreciate that in Rwanda, penetration is at 89%, and Uganda wanted us to borrow and leave from Makueni. You note that in the new NHF Amendment Act of 2022, it provides that benefits are renewed every 2 years, and the benefits inform decision of what will constitute the premiums. From my presentation, you saw utilization is in excess of 89 to 91%. So if we were to reduce the premiums, then it will imply that we also reduce the 10 benefit packages that we administer. The same act says that we cannot take away the benefit packages, especially chronic ailments, that have been rolled out. So what can be done, and under the UHC dispensation, we are saying this, that those who can pay, to pay. Those who cannot be able to pay, let them be identified, and the government will pay for them. Now, the other issue was asked by Beatrice. I think she stepped out on, and the CEC Elgoyo Marakwet, on the issue of sharing utilization reports. I do not indeed there is a gap, but I want to say this, that for the counties that have approached us, and I want to attest, Ganda was in our office 2 weeks ago, we have been able to share a comprehensive report on utilization. Ganda, you can attest, it was quite detailed. I'm the one who prepared it. I've done one for Moranga where I noted there's a challenge with NCDs. We've done a few others, but what I want to say, the MOU that NHIF, through the Board of Management, and the government through the Ministry of Health signed with NHIF, if you look at section 3.2.1, provides that NHIF shall provide real-time data to inform decision making. If you look at section 3.2.8, it is a requirement that obligates NHIF to share utilization data, including enrollment, claim utilization, and any other expenses of the UHC scheme. And that is why we do prepare quarterly reports, which among others include a patient relationship, claims paid out per month, most frequented healthcare providers. We do share disease patterns and trends on the data we are receiving, membership utilization, that is the frequency of the use of the card. We also share the claim stages. When we say claim stages, we want to share with the county exactly what has been paid and what is pending. We also share specialized surgeries, what we call case code 15, total hip replacement, total knee replacement, open heart surgeries, and many others. To provide a lasting solution, because it's a lot of work, I will share with you my email so that you do write, and I also task our officers on the ground to prepare those utilization reports. And perhaps you can take my mail and the phone number, because I know very soon you'll be looking for me. I'll start with my email. My email is, it's actually G-Osoro, G-O-S-O-R-O, at nhif.or.ke. Kindly do write, and I'll request you write through the CEO because I work under him, and I'll share with you the CEO's email address, which is pcamuño@nhif.or.ke. Write to the CEO, copy me, asking to be given a copy of the utilization report for your respective county. I'll be able to share a detailed report. Remember, we are in the era of data protection. And as a data officer, I'm obliged to have something in my hand, because we are not allowed to just ask for data. So I'll also write to ICT to do data mining to enable me process the data. That one will be done. I'll promise you within 3-4 days, we can share the data, but it's not enough to share data. It's also important we have a meeting, a virtual meeting, so that we tell you what we've been able to harvest, interpret the meaningful insights that we get from the numbers. I will go to the issue of reimbursement, and it has been noted that we need to make frequent reimbursements. Now, phone number. Sorry, I nearly forgot. My cell phone number is 0724 409619. Kindly call me during the official working hours and I'll be able to respond. Sometimes I may be overwhelmed, but I normally respond. As we continue, kindly also share with me your cell phone number. Write your full names and county. After this, my phone is off. I'll be able to save them so that for ease of getting to it. Okay. I'll go to the issue of reimbursement. I'm told I have a number of questions. Now, on the issue of reimbursement, it's part of what is provided for in the new contract cycle. And it states this way, that NHIF shall reimburse healthcare facilities within a period of, who has read those contracts? I'm sure Ganda knows. Ganda, tell them, what is the legal obligation? 60 days, and it's even put a penalty when we fail to do what? To reimburse. That's something I know many of you don't know. But the beauty is we do reimburse within a period of 25 to 30 days. When I did the utilization for Kisumu, Ganda will attest to you, we have reimbursed 94% of the claims that arose out of the Marwa scheme. For the national UHC scheme, we have reimbursed 84% of all inpatient and the outpatient, that is the capitation. So kindly, and we are under obligation, and I'll attest to it, that we are requested by the ministry that we should give preference to government facilities when it comes to reimbursement. Katra, that one we are doing. And thank God you sent 2 board members from COG who are now in NHIF, so they normally follow up. We will try to increase the frequency as we move up. What I'll tell CECs here is that we normally get very few claims from the facilities. Apart from few counties, you had the case of Nakuru, because of the FIF, they moved from 500 million to 1.2 billion. And I want to invite you people to come and benchmark in Nakuru. See what they did right. One of the investments they did was to train the officers who man the NHIF office, who sometimes are erroneously referred to as NHIF staff. They are not our staff, they are employees of the county government. What is important? Try to motivate them by even buying them 10 o'clock tea, and call our officers to train them. I can see the benefits that accrue from capacity building. On the issue of UHC size that was raised by my brother from Elgeyo Marakwet, now, we work with the data that we get from the Kenya National Bureau of Statistics and what is in our database. And I wish to confirm that what you said is true. As per our database, and we go as per the members who are declared and captured in the database, the average size of a household is 3. If you look at the Kenya National Bureau of Statistics report of 2019, the average size of a household is 3.8 or 4. Reason being that, even for the UHC indigents, you find that the principal members are not onboarding their spouses and wife. And we have a serious gap there. As you go back, kindly, Waziris, go and at every public forum, remind the audience to visit the nearest NHIF office and declare their dependents. And nowadays, we have undergone digital transformation. I'll allow you to remove your phone. If you send a text message to 1550, which is the USSD code, the short code for NHIF, and the contents of the message should be, you type ID, not the full name, ID, type the ID number and send to that line. It will give you the full details of the principal member, the declared spouse, and the contribution history. Are we together? Let me repeat, I'm told, if you want to know the details that are captured in the NHIF system, you can send a text message to to 1550. 1550 is the USSD shortcode that NHF has procured. The contents of your message should be type ID, write the actual ID number, ID 1, 2, 3, 4, 5, 6, 7, send. You will get a prompt reply indicating the full name of the principal member, the declared spouse, and the children that are captured in our database. So there should not be any excuse for one to say he doesn't know who he has declared in the database. That is another take-home assignment, one of the new things that you've learned today. I'm seeing some people smiling. Has anyone gotten it? Have you sent and received feedback? Yes, by a show of hands, let me see. Yes, it took less than half a second. So tell your people wherever you meet them, it's important they declare their next of kin. So we will come back to the issue of sensitization. We did our first sensitization in August, and we wish to thank AMREF who have been assisting us on trying to see how best we can engage in beneficiary education. I'm happy we have some donors here, Wairimu, I'm seeing PEF and others. When we will write asking that you support us on training of community health workers, kindly don't get tired. Let us join hands as we work together to ensure 100% attainment of UHC, because I realize it's a big problem. There's the question that was asked by Katra, and a very important question, on the disconnect between NHIF, COG, and Waziris at the county. Now, we had a very huge challenge when we first tried to process data that was submitted by the county governments through the State Department Social Protection. When we received data, we got data for around about 1.1 million indigent households. Now, the process of data cleanup, what we call data scrubbing, requires that you take data through some processes before it is validated and auto-registered. The first thing we did what we call preliminary tests. We confirmed that the data that we received had the correct ID numbers. And you know, for ID numbers, it should have how many digits? 7. Some of them had less digits, 5, some had 9, others had null values and duplicates. So out of the 1 million indigents that we received, 300,000 or 30% was rejected by the system. And key among them was the issue of duplicates, null values, others were non-existent IDs, and many others. So it took us time because we had to write back through CATRA, COG, and the team there to remind counties to resubmit additional data. This afternoon when I did my presentation, one of the take-home assignments that I left you people to do, as you leave here, because 1st January, we are onboarding additional 500,000 indigents. The million-dollar question will be, on 29th September, when you receive that memo, that you give us an additional list of 11,000 or 20,000, will you be ready? What we've done at NHIF, we have learned from our past mistakes. We have developed a software that is based on a program called Python, which I'll also request that you write to us requesting we share the software with you for purposes of doing primary verification of data. That software can do check for the null values. It can check for people, indigents in other schemes. In his OVC, we are talking of older persons and persons with severe disabilities and others. Before you send me data at NHF headquarters, you'll have done the preliminary cleanup. And what we are saying, when you write second names of ICT officers who will be trained on how to use that software before we do submission of data. The other thing is reimbursement, which was raised by Wasingishu County. There is what I call an erratic reimbursement, in the sense that we are not frequent. Under the issue of reimbursement, I'll classify it into two. We have capitation, which by law, if you look at the contracts that we signed with the county government, it requires that before the commencement of every quarter, NHIF shall reimburse counties capitation payment, that is for purposes of the outpatient benefit package. So every 3 months, you're entitled to receive capitation money. Are we together? This calendar year rather, from 1st January to 31st December, you should have received 4 payments for capitation, the last one that we just generated the other day. So take note of that. Now I'll come back to hospital claims. We are under obligation to reimburse within a period of 60 days, but we've worked over and above the calling, we reimburse within 25 to 40 days. But in event there is an inordinate delay in reimbursement, kindly feel free to get in touch with the team leaders at the branch. We have the branch manager. If the branch manager is not able to resolve your issue, we have also 6 regions that are spread across the country. We have Southern region that is based here in Mombasa. We have Western region that includes Kisumu and formerly Western Nyanza that is in Kisumu. We have the Eastern region in Meru. We have the Nairobi region and many others. So you can escalate your concerns to the same, or you can write directly to us and we'll be able to respond. We do have our challenge when it comes to the business intelligence system at NHIF. That is why we don't have dashboards. The current ERP that we have at NHIF was procured 22 years ago. It is a legacy system. It has outlived its sell-by-date life. And what we are doing, we are currently in the process of getting a new ERP. You may be aware the provisions of the NHIF Amendment Act 2022, Section 21, talks about the centralized healthcare management information system. And it expressly states that the board of NHIF shall cause to be established a centralized healthcare management system that, among others, will be used for claims processing, registration, and others. And it's an obligation that all healthcare providers who are empaneled and contracted subscribe to that system. On the issue of capacity building that was asked by Kajiado, we will endeavor to support you to the hilt to do capacity building for the staff who process claims. I'll request you to write to the region, to the branch officer who is based in Kajiado, and request him that you need the staff trained. You can even organize a forum after we've paid you capitation, nunulia ochai, take them to a small hotel so that they are able to be trained on the same. You know, Nakatrana provides security. I know time is not on my side. There were very many questions. On the issue of Ombati, on the issue of fragmented schemes, indeed, the current administration, if you look at the manifesto, which is now the government plan, noted that we have too many schemes that are overlapping, including the health insurance schemes, that is orphans and vulnerable children, older persons with severe disabilities. We have Linda Mama, Edu Afia, Inua Jamii, and many others. We are under obligation, and the ministry will attest, there is a long-term plan to collapse all those schemes into the national UHC plan. I'll answer the last one, which was asked by, I think, USAID on HIV and AIDS. I wish to confirm that indeed we do cater for HIV treatment in the various benefit packages. Be it the outpatient, including testing, it's covered, or when members who hail from HIV and they suffer from underlying conditions like Kaposi's sarcoma, NHIF is able to reimburse their bills. What I want to tell the team from USAID, we can sit down with you just like we sat down with patients who hail from drug-resistant tuberculosis, and we came up with a program whereby they are the donor who pays premiums for this cohort of members, and they are paid upfront, and they are able to benefit from the 10 benefit packages that we do administer. I'll request before you go, because I'm still around, if you can be gracious enough, we sit over there, tuonane nyuma ya hema, we discuss on this issue of HIV and AIDS. Thank you for listening to me. I know I had a lot, and I've taken a lot of time.
Thank you very much. I think one of the things that we are going to do and this is going to be our take-home message, and particularly after tomorrow, is we are going to look for some serious time, one day, only dedicated to NHIF, and we bring the CECs, the county directors of health and the chief officers, and we say, leo ni siku ya NHIF, hakuna partner ingine. While we have done our due diligence, then we come and get all of them, na tunawapeleka. Asante sana, my sister.
Thank you. I'll start from the questions from this end. First of all, thank you, Waziri Rotich. Yeah, thank you for welcoming your county, and I'm looking forward to working both the counties of the North Rift region. For the questions on the challenges, of course, any business setup in Kenya is not easy. We go through the challenges. It's not been an easy journey. Like Dr. Ganda mentioned, we started the journey 5 years ago, and we've just been able to achieve much at this beginning of this year, but we are thankful anyway. The first challenge has been regulation, and this also will be a challenge even as we look at expansion to other counties. You realize we are the first, what we call beyond visual of sight drone company in Kenya. So the regulation was there, yes, but there was no other person that had come and done this. So it's been quite a slow journey together with KCAA and of course the security agencies which own the airspace. The airspace in Kenya is owned by Kenya Air Force. So they have first to clear us in terms of doing their due diligence. So we made an application in September last year, and we only got a go-ahead in March. So the time, it takes so long before you get clearance from the security agencies. So that's one of the challenges. But of course, because they have to do their due diligence, they have to ensure you're not going to be hacked. They want to be ensured you're running safely in the airspace, you're not spying, our drones don't have cameras, so they have to confirm all these things. So one of the challenges has been regulation. Not only in areas it's there, but in other areas it doesn't even exist. For example, now when it comes to the Ministry of Health, where there's health, there's regulation. This is a new thing. How are you telling us you're going to transport blood? You know, how are we sure that the cold chain is, the cold chain you're saying, or the integrity of the product is actually going to be kept? Vaccines. Oh, how do we give you our vaccines? Are you going to, who takes care of them? Who's going to be accountable for them? What if they expire in your hands? So there's all this uneasiness that has to do with all the regulations, but it's been a journey, and we think now with especially the Ministry of Health agencies, after this first distribution center, it will be easier, of course, for them now to work with us with the next expansion phases. The other thing about regulation of the drone, it's a new thing in Kenya, even with just the communities themselves. How quickly are they going to accept this and understand it? Not only the community, even the learned community like us. We find even when you go to the counties, the first thing somebody asks you, drones, they tell you drones are not allowed in Kenya. So many times they tell you drones are not allowed, but you're like, no, they are allowed. Actually, we are registered. So that conversation starts from there. So most people don't even know about this new technology that is actually the technology of the world right now. So it makes the process of procuring very, very slow. The other challenge has been perception, and this ties to the cost. People think that technology is expensive, but technology is the other way around. Technology is there to bring efficiencies, and technology is actually there to make costs affordable. In most of the things that we actually do that is not really drone, but if you look at the technologies that you're adopting in your counties, they're actually bringing efficiencies and reducing costs. But the perception of drone, it comes across like it's luxurious. Like it's, and that's why I was saying it is made by styrofoam, to tell you that it's not something that went through a Toyota production. You know, it's something that is made in a little store in San Francisco with engineers, young engineers. So it brings the perception that it's expensive. And that already puts people off. Before they come to the table, they're thinking, we can't afford it. We can't afford that service. But they're not buying the drone. They're actually buying the service, the logistics service, the transportation of the product from A to B. So perception is the other challenge that we go through. Of course, the other challenge would be the process of procuring, considering it's a new thing. There's not been any other, let's say, framework contract that has been in existence. So it's starting with the counties from how do they do the UI, how do they do the RFP, I mean, it's been a great journey, it's been good learnings. But those are the challenges that have been there. So, and the most important one and the final one, because you're saying you want to take it back to your county, but you're wondering, will they accept? It's political goodwill. Not everybody has the same risk levels or the same visionary drive. And it's a new thing. Like he said, you're afraid that you're going to be fired because you're thinking this is something that you cannot benchmark with something else. So it takes brave people or very visionary people to actually say, let me take the step of faith like Kisumu County did, and they're going to be the pioneers. They're going to be the scapegoats. We're going to learn with them because also we are going to learn the systems, how Kenya health systems run. So we are all learning, but they took the brave step. So it's more of how visionary are you? And how brave are you to adopt this? And if you look at how the impacts that we've had in other countries, I think it's something that talks for itself. Yeah, so political good, like you said, we wanted to start in Makueni, Kajiado. We couldn't because there was no goodwill in the beginning. So we realized, let's try somewhere else. And then we found very good partners. The other question will be on the coverage. Let me now be quick. The other question, I'll cover the two of them on why not Lamu 2025 or 2050. I'll tie this to the expansion and the coverage area that Dr. Ombati brought up. So on the expansion, yes, we're actually planning to come to Lamu. And how we are planning to do this is actually through the regional blocks. So through, like now we are in Western because of the Lake Region Economic Bloc. They will enjoy the economies of scale because they will sign up together and then we will distribute the resources. They will share the number of flights, for example. So in Lamu, I think we are trying to work with the Jumia, I don't know, Yapwani. Yes, so we're trying to work with them and we're going to come to you guys very soon. And towards the north, the FCDC and all that. So that is the expansion plan using the regional blocks so that they can all enjoy the economies of scale. On coverage in terms of other counties are small, other counties think that they have better infrastructure of road. I want to retaliate, it's not about how good your roads are. Your roads can be very good. They can be well tarmacked. But do you have the products? The products may be in the regional medical store that will take another 1 or 3 hours to be driven to where it's needed. We take 20 minutes. So it's about speed. If it's an emergency, it doesn't matter how good your roads are. If you don't have blood, you will not deliver it. So it's not about the road network, but rather the service and what are we trying, which gap are we trying to fill? We are trying to fill that gap for, you cannot predict maybe some use of products like anti-snake. You can't know when it's going to happen. But when it happens, the product needs to be available at that particular time. Just in short and others. On costs, as I wind up. Costs, first of all, let's appreciate there's no costs that you can attach to saving a human life. I think that one we all agree. Like Pia said, it's all about humanity. So that cost of, it doesn't matter how much it will cost. But again, the cost is very favorable. We have different ways of how we cost this. And remember, we are actually just charging you the logistics. The same way you pay boda or last mile delivery with any other, let's say, cars that you use, is the same way we cost. But it's actually cheaper. And we cost them in terms of bundles. Maybe, for example, you can say as a county, we want to buy 1,000 flights a month. We don't charge per kilometer. We don't charge per weight. We can fly as many times as you want, and we bundle that in like a service fee every month. That this, we can give you 1,000 flights or 4,000 flights at this particular cost. And it's always cheaper, even if you want to divide it by per flight. I can guarantee you that. And who owns the product? The final question, it's actually you. We are not involved in sourcing of products. We actually get the products either from, like I said, we register ourselves as a depot, whether from the NVIP or we get the products from the county's allocation. The county now gives us part of the allocation to centralize it in our warehouse so that we are able to distribute it when it's needed.
Thank you. That was comprehensive enough. Your bundle ni shilingi ngapi ni nyuma ya tent, eh? Dr. Helen? And just we wrap up so that we can get some few minutes out.
Okay. I don't know whether to say I'm lucky. I got only one question, but thanks, Waziri, for the question. Yeah, just very quickly on why and how we adjusted the maternal mortality rate. So when the figure was launched, I think we queried, we actually engaged our partners, our technical and development partners, WHO, some UN bodies, UNICEF, count down to 2030, who are really critical in some of these calculations. And we looked at the data together. We organized ourselves and sat together with the Bureau of Statistics and CRVS. And as a group, I think we thought this figure really had a lot of issues. For example, the census, unfortunately, has a problem of underreporting deaths. So for example, we usually record about 450 deaths per year, but the census recorded only 150. So in this calculation, maternal mortalities were fewer by a similar proportion. So they were multiplied by a factor, and there were a lot of issues in the way that data, as we agreed as a team. So what we did is we looked at, between the two census, what was the proportional reduction in mortality, which was 40%, and that is what we applied to the previous figure of the DHS, the Demographic Health Survey 2014. That's how we came up with the 249. We'll share the report, but as I said, we hope to do this process at the county level, but I think that report we'll be able to share with you. So it was not based on fear. Of course, looking at the figure, I mean, we were 362, and we are talking about more than 7 years, coming to 355 with all the investments. We didn't think it was logical. The other issues we looked at was deliveries in health facilities. 80% of women in Kenya deliver in health facilities. That also means a lot of the deaths will occur in health facilities. So when you view 355, and even assume deaths in health facilities are 250. Right now, as I presented, our data shows about 100, 110. So in health facilities, we also know there's a reporting of deaths, maternal deaths, because no one wants to report that a mother died in their hands. So even if we assume this 50% under reporting, and assume that 240 women die in facilities, if you look at now the 20% who deliver in communities, of course you expect the maternal mortality to be higher, but then if you use 355, it was giving us a community maternal mortality of 1,200 and above. So the new adjusted figure at least gives a reasonable community rate of 472 deaths in the community. So it was quite a rigorous process, and we hope to do the same for county, so that we can have figures that we actually have confidence in. I hope that answers the question and not creates more questions. Thank you.
Okay. Thank you very much, Dr. Helen. I think as we go on, one of these coming years, we are going to share real data. How many mothers died in Mandera? How many died in... There's nothing to run away from. If it is a shame, it is our shame. It is ours to correct. So we need to have the right figures. The only problem that I know that is there is the community deaths. These ones are difficult, unless maybe a law that prohibited FGM. Plus, we also have the problem of international deaths in court. You have got mothers coming all the way from Somalia, complicated, coming in the last, HBs of, they're coming eclamptic, and then you put them in ICU, try to salvage them, and they're gone. They also become part of what happens. Are they part of these statistics of people that we report? And they are not even Kenyans in the first place. Robert?
Okay. My final comment on NHIF. My final comment on NHIF, the issues you've talked here about NHIF, sharing reports and all this, I think we are not addressing the root cause. The root cause is we are operating as two entities. NHIF is operating independently. Health sector is operating independently. The best approach would be NHIF is part of the health system. So my advice as we live here as CHMTs, the best way is ensure at the county level, as you are doing your CHMT meeting, co-opt the NHIF member at the branch level as part of the CHMT. The questions that we are raising here, if you had a CHMT member from NHIF co-opted, you'll not even have a question towards NHIF. We'll address a lot of issues. The same NHIF that is paying 1.something billion in Nakuru is the same NHIF that is paying less than 10,000 in another county. So that's my advice for today.
Thank you, Robert. Manosoro says he wants to pass one very important message. Do I give him the mic or we tell him ka? Yeah, Manosoro.
Thank you for allowing me to come back. I wanted to make this a major pronouncement. About a fortnight ago, the Supreme Council of Kenyan Muslims, SUPKEM, the Jamia Mosque Committee, and Ulamas in Nairobi issued a religious edict, fatwa, declaring NHIF to be legit or halal. The net effect is that we wanted to reach out to our brothers and sisters in the Muslim community. It was in the magazine last week. I'm seeing Katra smiling. As you go back, we are developing a product that will be Takaful aligned specifically for this cohort. So we have good news. When we shall call for the national launch, and I want to start with your county, where we will do the launch for the Takaful product for NHIF. Thank you and God bless.
Thank you very much. Now, I think let's be upstanding. We give the team a round of kilo clap. Sindio? Aya. 1, 2, 3. Funga. Fungua. God bless you all. Thank you so much. Okay, panelist photo.
Hello. Thank you very much to our panelists, and thank you very much to all our CC who have seated in from 9 to now. At least we managed to complete the program, and we really appreciate you. I've not seen the class being quarter full. The class has been full house. So we again, I said we are going to share this presentation with you on your emails, but the photos and everything will again be shared today. So every successful day, we started with a word of prayer. We need to close with a word of prayer. Tomorrow will be our last day. If we come very early, I think we need to agree. If you come early, we just finish early, and then so that you can have time to go to the beach. Courtesy of Zipline, we have a cocktail. And Jerry, where is it served? During the dinner, where? Kindly come and see.
It's next to the main restaurant where we were having our lunch. So it will start at 7, where you'll hear a small band playing. That's why we are set up. Karibuni.
Kindly go and refresh yourself, energize yourself, and prepare for tomorrow. So somebody to lead us with a word of prayer. We need to have pastor from the new CECMs. Waziri, njoo uonekane hapa utuombe, tufunge mkutano. Tafadhali, let us meet next behind the restaurant for a quick cocktail starting at 7.
Good evening, everyone. Just before I pray, allow me to just make a comment about NHIF because I didn't get a chance to ask for my question. But there is an article that was written in Al Jazeera on the 13th of December about reducing maternal mortalities in Nandi County, and they actually quoted Linda Mama because it is one of the reasons we were able to have our maternal mortalities in the last 5 years. And also on the big strides on what NHIF has done with the packages, I think if we can educate our citizens so that they can value having health cover, because many people will have it when they are done, they stop paying for it. We can have even better packages. And also if we work closely with them, I think they will also be looking at financing transplants and the medication for transplants because it's more expensive to pay for dialysis. I think that's just my comment. Okay, let us pray. Can we pray? Guys at the back? Can we pray? Okay, let's bow down and pray. Dear Heavenly Father, as we come before you this evening, we'd like to thank you for this beautiful day. Lord, we would like to thank for all the partners, the leaders, the secretariat that is here with us in these 3 days. We pray for your wisdom, your guidance as we plan for the healthcare in our counties. And as we depart this evening, we pray that you will protect us throughout the night until we meet tomorrow morning. All these I ask, believing and trusting in Jesus' name. Amen. Thank you.